So very good afternoon. We are back. Second series of my 3 series talk. The first one was updates in steroids for WADA. Second one is Journal Club. We are reviewing 2 systematic reviews. What is the safety and efficacy of PRP and HA, combination therapy in AOA, and our last topic is concussion in para-athletes. Alright. So with the rise of popularity and use of the combination of HA and PRP for AOA, also which applies to our own clinic, I was wondering what was the evidence and efficacy of this treatment. So that's why I chose this one. So just a bit of information. Platelet-rich plasma is an injectable solution containing platelets centrifuged from an autologous blood, and these platelets are concentrated over baseline. Contains over 1,500 proteins. They have anti-inflammatory and anabolic proteins. Mode of action is not completely understood, but in vitro evidence shows chondroprotection, chondrogenesis, and decrease of chondrocyte apoptosis. Hyaluronic acid, on the other hand, is a polysaccharide, which is an important part of the synovial fluid and articular cartilage. The function is to 1. Physically lubricate the articular surface, reduce wear, and biologically nourish articular cartilage. HA promotes synthesis of endogenous HA. So what is the rationale for the combination of the two? There are 2 solutions with distinct and complementary effects. PRP is a pure biologic, and HA is a mechanical and a biologic, has mechanical and biologic effects. In vitro studies of PRP-HA combination on the knee has found that there is repair of degenerated cartilage, changing or suppressing of inflammatory cytokines, and promoting cartilage regeneration. So, I did a PubMed search of systematic reviews reviewing HA and PRP combination in knee OA. This actually yielded 3 systematic reviews. These were the 2 most recent ones, and interestingly, they gave different recommendations. So, which one is right? When we have a look at the papers, the title Treating Knee OA with PRP and HA Combination Therapy, a Systematic Review, was authored by Michael R. Baria. He's a sports physician in Ohio State University Sports Medicine Research Institute. The journal was the American Journal of Sports Medicine. It's an American journal, it says on the tin, and it's a Q1 journal. This was published in January of 2022. The purpose was to systematically review the clinical literature examining the combined use of PRP and HA in AOA. The design was a systematic review. There was no meta-analysis, and they mentioned that they follow the PRISMA checklist. Database reviewed was PubMed and Embase. They reviewed 8 studies, 2 of which were case series, 3 non-randomized cohort studies, and 3 RCTs. Their conclusion was that combination of PRP and HA improves patient-reported outcomes and is superior to HA, but is not superior to PRP alone. Their recommendation is that they do not recommend PRP plus HA over PRP monotherapy. So this is the gist of the first paper. Our second paper is entitled Effects and Safety of the Combination of PRP and HA in the Treatment of Knee OA, a Systematic Review and Meta-Analysis. The author is Jinlong Zhao of Guangdong Academy of Traditional Chinese Medicine. Don't be fooled by the name, because it's actually a research team on bone and joint degeneration and injury, and they do publish quite a lot. The journal was BMC Musculoskeletal Disorders. It's an open access peer-reviewed journal from the UK and XQ2. They published this earlier than the first paper. This was published in April 2020. The purpose of this paper was to explore the efficacy and safety of intra-articular injection of PRP and HA compared with HA or PRP alone. Design was a systematic review with meta-analysis, also mentioned following PRISMA protocols. Database, they reviewed PubMed, Cochrane, Embase, China National Knowledge Infrastructure, and they mentioned that they covered other sources, which is literally just a review of references in by-hand searches. They included 7 studies in their paper, 5 RCTs, and 2 comparative cohort studies. The conclusion was that 1, PRP and HA can significantly improve the VAS score, the WOMAC function score, WOMAC total scores, and the personality index scores when compared to PRP alone. There was no significant difference of adverse reactions between PRP and HA versus the PRP group. Recommendation was that PRP and HA may have promising clinical effects on knee pain, and they suggest that PRP and HA is better than PRP alone. So, which do we take? PRP plus HA is not better than PRP alone. PRP and HA better than PRP. That's not simple. Any views on anyone who's read the paper? Would you pick one over the other?
Any paper?
The support. Who supports the China paper? No. Easy for you to remember. One is Maria et al. It is the American paper, and then you have the China paper. So, with what I gave you just now, actually, it's not enough information to pick out which paper is better. You can't pick out like, oh, it's a Q1 journal and that's better, Q2 journal not so good, one from China, one is an American. So let's look closer into what they did. So, Maria et al., the first paper, they analyzed 8 studies, 2 case series, 3 cohorts, 3 RCTs. They did a Coleman methodology score, which is scoring the methodology of each of the studies in their paper. So with the Coleman methodology score, it only assesses how good the quality of the paper is. Above 50 is a good score, below 50 is a poor score. So they wrote in their paper that most of the studies in their systematic review was of poor quality, but because they had very limited amount of studies on this topic, they accepted. They suggest that in further studies, once you have quite a lot of studies, you pick those with a higher score. Okay? So what did they find? When they compared PRP and HA versus PRP, this was 2 RCTs and 2 cohorts, there was no statistical difference between the groups. When they did PRP and HA versus HA alone, 2 RCTs and 1 cohort, PRP and HA was superior to HA. Their 2 case series was PRP and HA. They didn't compare to anything because it was a case series, but both showed improvement in patient-reported outcomes. The interesting thing about this systematic review was that 4 studies used cellular matrix, what we are using here. And 4 studies used independent labs. The injection regime for cellular matrix was interesting because they used 3 injections spaced 1 to 3 weeks apart. As I understand, what we're doing here is cellular matrix, but 1 injection. And I don't think we do 3 serial injections. So their studies were 3 serial injections. Yeah. Did we do 3 serials?
The suppliers
Suggest.
but due to lack of money
Cost.
there are very few patients to sustain on that.
Where they came up with the 3 injection series, I've actually not found
Italian people.
Italian. Nanti was share. I haven't found that yet. Thank you. 3 studies used single injections. So the single injections were really the independent labs, and then the 3 injections spaced 1 to 2 weeks apart is the cellular matrix. So the second paper, Zhao et al., they reviewed 7 studies, 5 RCTs and 2 cohorts. The good thing about this paper is that they reviewed the risk bias for both the RCTs and cohorts. They also reviewed the risk of publication bias. They also reviewed the quality evaluation of all the studies. So the difference between the 2 big ones is that there is a risk of bias evaluation in the Zhao paper. Meta-analysis findings, number 1, for pain score PAS, there was no significant difference between PRP and HA versus PRP in the first month and the 3rd month. But at 6 months, PRP and HA was superior to PRP alone. So we find that at 6 months, the PRP and HA showed better results in pain score. Womack function at 12 months, PRP and HA was superior to PRP. Womack total at 12 months, PRP and HA was superior to PRP. The worsening index is an index for knee pain, knee OA. At 6 months, PRP and HA was superior to PRP. And adverse events, there was no significant difference between both groups. So what I did for the two papers was to review the quality of a systematic review. M-STAR is a measurement tool created to assess the methodological quality of systematic reviews. Why should we assess quality of systematic reviews? Number one, there's an increasing number of systematic reviews published. Systematic reviews are subject to biases and we use systematic reviews to make decisions. So you need to know that systematic review, how good is the quality of it. So we use M-STAR to identify high quality reviews. How does M-STAR help? It assists us in the identification of high quality systematic reviews, and it takes into account non-randomized studies. Some tools only review randomized control studies, systematic reviews that have randomized control studies in. And M-STAR is recommended by the DHA. So the rating is very busy, the slides. All you need to know that you have low and critically low, and these two should not really be relied on. So if you do your M-STAR rating and you have low and critically low, you might not use these systematic reviews in your decision making. Then you have high and moderate, which is an acceptable systematic review. So this is the M-STAR review, also very busy, but what you need to know is just this. For Baria et al., they have 3 critical flaws and 1 non-critical flaw. In their method and protocol, it's a critical flaw because they didn't do a risk of bias assessment. They did the Coleman, which is how good the study is, but it doesn't really touch on the risk of bias. Risk of publication bias also within practically. So selection of study designs is a non-critical flaw. Risk of bias assessment, including studies, and discuss risk of bias. So everything was tied into risk of bias. If you don't have this, you don't score very high on this review. For Zhao et al., they only had one non-critical weakness, was that they didn't explain why they decided on certain studies. So based on this, Baria et al. Received a critically low score, and Zhao et al. Received a moderate score. Baria had 3 critical flaws plus 1 non-critical weakness, and this review has more than 1 critical flaw and should not be relied on to provide accurate and comprehensive summary of the medical science. Moderate means but even with this type of scoring, it's how well you write the paper. So you have to still look back into the paper. And there were a bit of questionable results. Baria et al., because they published after Zhao, they did reference Zhao. They only reviewed 2 studies which overlap. They did not review 5 out of the 7 Zhao studies because they said that it was not in English. However, one of those studies was actually in English and you could access the paper easily. So a bit iffy why they didn't review that paper. The other papers were really not available and there was no risk of bias assessment. Zhao et al., they did not include Lana et al. And Jacob et al., which was published in 2016 and 2017. These 2 papers were discussed in the Baria et al. Paper. They are quite good studies. Despite fulfilling the inclusion and exclusion criteria, and their search was till December 2019, they didn't discuss these 2 studies, which may have changed their results. 4 out of 7 papers were really not available. So the issue with a well-written systematic review that scored high, but we can't access those 4 out of 7 papers. It means we have to take their word for it, what they say is the results, and what they review is correct. See for yourself. So that's a bit of prejudice. So what can we conclude from these 2 papers? Both papers had strengths and weaknesses. Baria et al. Had more weaknesses than strengths. But at the most conservative, for me, I would take number 1, there is no difference between adverse reactions between PRP and HA and PRP only groups. I think all of the studies that they reviewed, we can safely say that PRP and HA and PRP, the adverse reactions is about the same. PRP and HA, PRP only, and HA only, all result in statistically significant improvement in PROs. All 3 of these treatments will result in some improvement in your patient. How much they improve and how long they improve is what is the difference. But all three cause renal movement. None of them cause either stagnation, the same, or backwards, means it makes the situation worse. PRP and HA, and PRP only is superior to HA in terms of improvement in PRP. Most of the studies at least can conclude that anything with PRP, actually, PRP and HA and PRP alone, when we compare it to HA alone, injections with PRP do better. So the question now is between PRP and HA and PRP only. There was no significant difference between HA and PRP versus PRP at month 1 to 3. So early on you don't see much of a difference, but there may be a unique advantage of HA and PRP in the long term in relief of pain, function in your 6 months to 1 year. So based on all of the two systematic reviews, this is what I believe we can conclude from the 2 papers. Further studies needed, a lot of further studies are needed as always with all journal clubs and systematic reviews. Studies using cellular matrix, or this one I think was answered, I will look at it before. Other protocols included single injections. There was another protocol in one of the Chinese papers where they did weekly injections for 8 weeks, means the patient received 8 injections. So there's a lot of variability between the injection protocol. What we are injecting. Optimal PRP formulations, we still haven't gotten an answer. Platelet rich, leukocyte rich, leukocyte poor, do we single spin, double spin, activated, non-activated, we combine it in one injection before we inject separately. All of these studies mention all of these things, as in separately. One study did leukocyte rich, another did leukocyte poor, some single spin, some double spin. Lana et al. Injected separately, I think, and some activated it outside. So because of all this heterogeneity, you can really make a clear result of the study. Optimal HA, when we're going to mix with PRP, is it a low molecular weight, which is better, high molecular weight? How much volume? Cellular matrix, I think, is 2 ml of HA. So how much, if we're going to combine PRP and HA, are you going to use a low molecular weight or a high molecular weight? And how much volume are you going to put in? These questions, there are still no answers. But because we are already using the technology, we should at least know a little bit about how well it works and if it works, especially with Malaysia and cost. So that is all for my presentation. I promised 20 minutes, 21 minutes. And if these are the references, if you have any questions, if you would like to go through the papers.